Broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to today's webinar. Today's webinar is entitled Care of Acutely Ill Older Persons Living with Frailty, Making Healthcare Work Like a System. And today's presenters, we have Dr. John Hurdies and Dr. George Heckman joining us from the University of Waterloo. Just a couple notes. My name is Amanda Lorbergs. I'm the Manager of Research and Knowledge Translation here at CFN, and I will be hosting today's webinar. Once the presenters have completed with their presentation, we will answer questions, but the ones that you enter in the chat box on the panel of the webinar app, and we'll get to as many questions as time permits in that before the end of the hour. Another reminder is that we're always looking to improve our webinar series, so please take a couple minutes at the end of the webinar just to complete the survey that will pop up on your screen. And as always, the slides as well as the video will be available online within a day or two at the link below. And we have, although we are in the process of booking more webinars, we have confirmed that on May 8th at noon, we will have a webinar looking at the wiki-based decision aid supporting critically ill patients. So keep an eye on your inbox for anything that may come up prior to May. And we have our annual national conference on frailty coming up at the end of September. So we are looking for proposals. So we invite you to submit your innovations for an opportunity to present. Another thing that CFN is working on is a project with CFHI, the Canadian Foundation for Healthcare Improvement. And we're working with the top 5 showcase winners from last year's conference to explore how we can spread their innovations. There's more information available on our website. Okay, so now we will go on and I'll introduce our presenters. First, we have Dr. John Hurdies, professor in the School of Public Health and Health Systems at the University of Waterloo, also a senior Canadian fellow and board member of InterEye. And we have also George Heckman here, associate professor with the School of Public Health and Health Systems at the University of Waterloo, and assistant clinical professor of medicine at McMaster University. He's also the Schlegel Chair, Research Chair for Geriatric Medicine at the University of Waterloo, our Research Institute for Aging. So now we'll go ahead and hand it over to you.
All right, Amanda, have we got the correct screen showing there?
I don't see the PowerPoint presentation.
Okay, I just need to then check to share the correct screen then.
Yes.
Well, how about now? Do you see the?
Yes, we see it little, and now you can go ahead and go into presenter.
Okay. Oh, and that's going to show us in presenter mode. My apologies.
That's okay.
So I'm just looking at the sharing. Okay, there we go. Let's change. That's changing the presenters. I'm trying to. Oh, there we go. Screen. Screen monitor 2, and does that work now?
There we go. You're all set.
Thank you very much. Thank you, everybody, for joining us today. My apologies for the short technical delay there. This is John Hurdies speaking. I'm joined by my colleague, Dr. George Heckman, and we're delighted to have this opportunity to present to you the results from a large Canadian Frailty Network grant that we did entitled Care of the Acutely Ill Older Persons Living with Frailty, Making Healthcare Work Like a System. So what we would like to do today, if I could get my slides to advance here, that's strange. There we go. First of all, what we'd like to do is to talk about why it's important to think at the system level. Why do we need to take a systems approach versus just looking sector by sector? And related to that, we want to talk about why it's important to think about transitions in care, because lots of good things can happen in transitions, but lots of bad things can happen as well. We'll give you a bit of an overview of what's happening with inter-eye research in Canada, as well as the implementation of those systems. Then I will speak specifically about research we did with our CFN funded grant on transitions from long-term care to the acute care system and elsewhere in the health system. And then Dr. Heckman will talk about research we've done to pilot an inter-eye assessment in acute care settings with frail older adults. So let's start to think about why we need to think at the system level. And it's actually a pretty simple answer. And that is that people who have comparable needs get services in different sectors of the healthcare system. So if we look at the health system, not all old people are in nursing homes, not all people who are dying are in hospices, not all people who have mental illness are in psychiatric settings. In fact, these three populations who have complex needs get services across different parts of the health system. So an older adult living with frailty may encounter primary care, home care, acute care, long-term care, and palliative care at different times in the trajectory of change that they go through. And why that's important at the system level is that if we have people using multiple different types of services who have comparable needs, there might be some opportunities to fine-tune parts of the system to be sure that certain people get more intensive services in some settings rather than others. So we can recalibrate where people get care. So for example, the entire ALC issue is focused on this issue of the right person being in an acute bed versus somebody who has an alternate level of care being in a different type of support environment to get their needs met. But from the practical point of view of the person's perspective, a system level approach means that individuals have to deal with different providers at different points in time. They deal with their family doctor, they may deal with their doctor in an acute hospital, and they may also deal with staff in a long-term care home if they go in that direction. And having continuity of care becomes very important for them. So if you're receiving home care services, having a way that home care can speak to your primary care provider should happen, and it's really important that the two systems are working together to ensure continuity of care. So if we're trying to understand the healthcare system, we probably need to think about at least two concepts, and this comes from the drum corps literature. My son was a member of the drum corps at age 11, and I very quickly began to understand the importance about positions on the field and transitions that happen across the field as the drum corps moves. Bad things can happen if you're in the wrong starting position, and worse things can happen as you move between positions. So to understand the healthcare system, we need to think about the patterns of care that people get within a sector of care, but we also need to think about those transitions that happen between care settings. We also need to think about issues around equity and quality in the system. So to have an equitable, good quality system, we need a standardized approach across the different settings to measure things in a consistent way. And George, did you want to mention this 2014 study around delirium?
Yeah, sure. I think that this was conducted with the RGPs of Ontario, and they were interested in understanding what markers of senior-friendly hospital care could be measured at that time. And there were some volunteer homes who were focusing on just two indicators, that of delirium and that of hospital-acquired functional decline. Delirium, in terms of using instruments sort of like the CAM, was relatively doable in terms of the ability to measure it across the system, but very few hospitals were actually able to measure whether a patient had undergone functional decline during their hospital stay.
So let's think about why we should care about transitions. Well, first of all, from the person's point of view, bad things can happen. The transition from one setting to another may itself be a very stressful event for the person. So leaving a home care environment and entering into long-term care can be a stressful transition. changing floors in a hospital could be stressful, and being discharged from the hospital back to the community can be stressful for the person as well. One of the bad things that can happen is that as we move from a familiar environment to a new environment, there may be a failure to detect needs in the new environment because they're just not aware of who you are as a person. And not identifying those needs can lead to other adverse outcomes like decline in functional status, depression, and there is some literature around the risks associated with relocation and mortality. So there's a number of ways that it can have an impact directly on the person. From the organization's point of view, any transition into a setting can involve some degree of disruption to staff, that there's somebody new that they need to work with. For other care recipients, there's a new person in their care environment that they may need to deal with if we're talking about a facility-based context. And it's particularly problematic for the organization if the person entering into the service setting isn't a good fit with the types of services and supports that can be provided in that context. And if we think about the health system overall, a concern is that access to different services that are needed could be blocked by people who need a different level of care, and access to those beds isn't easily available to other people who have more intensive needs. So, for example, the ALC problem in hospitals would illustrate that. And we also have the potential that if an avoidable decline happens, that adds new costs to the health system that didn't have to be incurred. So thinking about these transitions is important from just about any perspective you take, whether you look at it from a human rights perspective and from the individual's perspective, or the efficiency of the health system, and thinking about things like ending hallway medicine by having better access to care for, we're matching services to the needs. We have to care about transitions at all levels. So this is, I think, where the Interact family of assessment instruments can help. We now have a very comprehensive range of instruments covering the entire spectrum of healthcare settings, from mental health and long-term care settings for adults with intellectual disabilities in residential and community settings, in home care for both young persons and older adults. We have a community health assessment that's designed for community support services. We have a new family of acute instruments that George will talk about in his presentation. We have rehab and post-acute care instruments, a palliative care instrument. We have a new primary care tool, both a clinician-administered version and a self-report version, an instrument for community rehab clinics, a caregiver needs assessment, and a variety of subjective quality of life assessments. So we actually have measurement systems now that are designed to work as an integrated health information system spanning all the major sectors of the healthcare system. This graph shows what's happening in Canada today with respect to implementation of these different systems. And so if we think about these icons where it's a solid icon like the red dots, those mean that the government has mandated implementation either province-wide or in major geographic regions within the province or territory. If it's a hollow dot or hollow symbol, it means that there's research projects, pilot studies, or other kinds of implementations underway. So in the nursing home and home care sectors, all provinces, but except for Quebec, are either implementing now the home care and nursing home instruments, or are planning to in the near term implement those systems. Other instruments that are widely used in Canada are the mental health instrument, the inter-eye contact assessment, the palliative care instrument, the brief mental health screener, which is used by police officers for screening mental health related apprehensions. So there's very pervasive use of these instruments in the country, to the point that now, as of about 5 months ago, there were over 13.5 million different inter-eye assessments done on well over 3.5 million different individual Canadians. So these instruments are very pervasive in their nature. They can be considered to comprise an integrated health information system because they use a common terminology, a common language across different instruments for how they describe different concepts. There's a common theoretical or conceptual basis for identifying triggers for care plans as the way we've designed the instruments. There's a common clinical emphasis on function rather than diagnosis alone. It captures diagnosis, but goes much more broadly than that. Common approach to how you gather data using professional assessment skills and best clinical judgment using multiple sources of information to inform your judgment. There are common core data elements that appear across all instruments, and I'll show you an example of that in a few moments. And there's common care planning protocols for adjacent sectors of the health system so that you can work collaboratively with a transition from one service setting to another. So this is an example of having common core where it can be very useful in terms of supporting care across the system. So what we have is the cognitive performance scale, which is a 7-point scale ranging from 0 for cognitively intact to 6 for very severely cognitively impaired with end-stage dementia, measured in a number of different service settings. So we have a general psychiatry population, palliative care settings, community mental health services, community support services, home care programs, complex continuing care hospitals, geriatric psychiatry units, and nursing homes. And what you can see is that as you move from more community-based populations, the distribution of the cognitive performance scale shifts from being at the left-hand side of less cognitive impairment to the right-hand side of more severe cognitive impairment. So in terms of the shape of the health system, that kind of makes sense, that people would be more likely to be in an institutional setting if they have severe cognitive impairments, whereas if they're cognitively intact, they should be in the community. We would wonder about these populations like the people in community settings with very severe cognitive impairment, whether they're going to be able to stay in those settings for very long. And then there's these folks in the back left-hand part of the diagram that are in institutional settings, even though they're cognitively intact and probably could direct their own care. And so they may be an inappropriate fit there. They could potentially be in a more independent service environment. So now I'd like to move into the focus of our previous Canadian Frailty Network funded grants, where we did extensive analyses of those data holdings we have in INTRI to look at transitions from long-term care. Our foundation for this was something called the INTRI CHEST scale, which looks at changes in health, end-stage disease, and various signs and symptoms. So it's a summary scale that takes into account decline in cognition and ADL. It looks at whether you've got a prognosis of less than 6 months to live, and a variety of symptoms that are very commonly associated with things like cancer or heart failure, things like weight loss, edema, shortness of breath, and so on. The scale goes from 0 to 5. And in this paper that we published previously, we showed that this scale is highly predictive of mortality in complex continuing care hospitals, in nursing homes, and in home care settings. And so what we were interested in was in transitions in CHEST states, as well as transitions out of the hospital setting. We've already got 3 papers either published or in press from this work. So George led a paper that has been published in JAMDA on looking at transitions in relation to heart failure in nursing home residents. Our colleague Paul Hebert has a paper about to come out in CMHA Open that looks at provincial transitions, or provincial variations in transitions, both from acute care and long-term care. And I led a paper that looks at the impact of day of stay on transitions from long-term care settings. All of these are related to the same kind of models, which I'll show you in a moment, and we'll illustrate using advanced directives as an example. So the way we designed this analysis is we use multi-state transition models, which use Markov chains for longitudinal analysis, where instead of modeling one outcome at a time, we're modeling multiple different outcomes. So if you imagine a hockey analogy, if you do a logistic regression or survival analysis, you're basically looking at one player at a time moving across the ice surface. With multi-state transition models, you're watching the behavior of the whole team. So instead of just watching a transition to death or a transition to hospital or to home, you're watching all transitions at once in these environments with these more sophisticated models. So in our model, we look at the impact of a given variable after adjusting for all these covariates that are listed on the left-hand side: age, sex, marital status, cognition, ADL, different diagnoses, and advanced directives that we're going to be showing you as well. We start with 3 different chest states: people who have a chest score of 0, of low health instability, a chest score of 1 or 2, with moderate instability, and a chest score of 3 or more, where mortality risk starts to go up substantially. So for people who stay within the facility, we're interested in transitions from chest state 0 to chest state 1, as well as from chest state 0 to chest state 3. For people who leave the facility, we're interested in transitions from chest state 0 to hospital, to death, to home, or to other types of settings like assisted living, going from long-term care. But we're also interested in transitions from the midpoint to a lower chest state or a worse chest state, as well as to those different settings outside of the long-term care home, and transitions from the highest chest state down to the lowest chest state, the middle chest state, and to those different destinations. So for people who stay in the facility, we're interested in, did their health get worse or better? And then for people who left the facility, we're interested in, did they go to hospital, did they die, did they go to assisted living or some other setting, or did they go home? So these are the typical tables that come out of our analysis, and let me explain a few things about these tables. On the left-hand side, we've got the baseline chest scores of 0, 1 to 2, and 3 or more. So this is the starting point of the chest score that the person had while in the long-term care home at admission. And we have 2 covariates we're interested in. We're looking at do not hospitalize orders and do not resuscitate orders being present or not, where the reference group is not having them present. And then we look at different states. So for the people who stay in the nursing home, we look at the transition to the different chest states of 0, 1 and 2, 3 or more at follow-up 3 months later. And what we have in the cells are the odds ratios for those transitions after adjusting for all those different covariates. The next set of columns are transitions out of the nursing home, transitions to hospital, death, discharge to other settings, and discharge home. So let's see what we can understand from this model then. In purple, I'm highlighting the odds ratios for the impact of having a do not hospitalize order and a do not resuscitate order on transitions to worse states, going from a chest score of 0 to a chest score of 1 or 2, or a chest score of 3 or more, for both the do not hospitalize and the DNR orders. And what you can see is that there's a modest relationship between having those directives present and a transition to a somewhat worse state. The next set of cells on the table deal with the transitions to a better state, because now you're going, for example, from a chest score of 1 to 2 to a 0, and what you see is all the odds ratios are protective. In other words, that with a do not hospitalize order, you're less likely to get better in your chest scores, whether you start at a 1 or 2 or 3 or more. And the same is true if you have a do not resuscitate order. So you're slightly more likely to get worse, and you're less likely to get better when these orders are present. Next, we'll look at admissions to hospital. So I think it's a good thing that if you have a do not hospitalize order present, you're less likely to go to hospital. Somewhere between a 0.67 times less likely to go to hospital for chest scores of 0 to a 0.47 times for the chest score of 3 or more. So that's you're about a third to a half less likely to go to hospital if you have a do not hospitalize order, which is consistent with what you would have expected from that advanced directive. If we look at the do not resuscitate orders, the associations are a bit weaker, but still in the same direction. If you have a DNR present, it means that you're less likely to go to hospital, and that's particularly true for the chest 3 or more. Next, we see that if you have a do not hospitalize order or do not resuscitate order, you're also more likely to die in the various chest states when you have a do not hospitalize order and present, somewhere between it's roughly 1.5 times greater adjusted odds. When we look at the do not resuscitate order for 2 of the chest states, the odds ratio is about 1.36 to 1.38, so also increased odds of death when a do not resuscitate order is present. If we look at discharges to other service settings, it has no impact on a discharge to something like an assisted living setting if you have a do not hospitalize order. But if you have a do not resuscitate order, you're less likely to go to those other service settings like assisted living for the first two chest aids. And finally, if we look at going home, there's no impact of the do not hospitalize orders on going home, but there's a protective association, so you're less likely to go home if you have a do not resuscitate order in place. Now, we have to be careful here that we can't really make causal inferences. These are lagged longitudinally, so it is the presence of the do not resuscitate order or do not hospitalize order at time 1 and outcomes at time 2 that occur after that. So the longitudinal sequence is correct, but there may, for example, be some third variable that is predictive of having a do not resuscitate order present that also makes it less likely for you to go home. So we just need to be careful that we don't get too causal in our interpretations here. So what does all this mean? What it means is that advanced directives in long-term care are associated with transitions from nursing home to hospital settings, death and transfer to other settings, and discharge home. It's also associated with transitions in health status among those who stay in long-term care. And what that means is that advanced directives do have a meaningful role in outcomes for persons in long-term care, that there's something consequential about having these in place. It's either reflective of some third underlying variable that affects your outcomes, or the decisions reflected in those directives do have some impact on things that happen to you later on in the organization. What that set the stage for was an important study that George and Alan Garland are now leading to look at an approach, a more systematic approach to advanced care planning to long-term care, within long-term care to improve end-of-life care. And I do want to apologize for the misspelling, the adding of the D to advance, but we'll ignore that for the moment. So that sets the stage for George to talk about our second project, our multi-hospital pilot of the intra-acute care instrument. Should be able to work with here.
Thank you, John. All right, thank you, John, and I'm very happy to be speaking today to all of you. And again, thank you for CFN for putting these on and for helping us and supporting our ability to do research. We're going to switch now to hospital care, and clearly in the news in many provinces is the issue of ALC, or patients with delayed discharge, generally in hospitals, but in other sectors like rehab units or other assessment units, mental health. And we do know that this is a major issue, and this is a paper that was published by one of our collaborators, Andrew Costa, a few years ago, which used information that is collected in ALC patients in hospitals, and using the hospital version of the RIHC. And this was used to look at their characteristics post their designation as ALC. And that's an important comment. We know an awful lot of what these folks look like after the fact, and this will lead to some of the reasons underlying our study of the hospital suite. So clearly, functional impairment, dementia are some of the major risk factors for becoming ALC in the hospital. There's a variety of other conditions, including fractures, medical complexity, antipsychotic use, previous stroke, health instability, psychiatric diagnoses, but also we see on the left side of the slide issues regarding socioeconomic support. So these are all important. The message is these ALC clients are extremely complicated, but they have conditions that individually and collectively we know how to manage them. And I note the very significant importance of social support as predictors of characteristics of people who have become ALC. So obviously we know what they look like after pardon my expression, things go off the rails, the question then becomes, could we be more proactive? And that's where the hospital systems from INTRI come in, and that's how they were developed. They were developed to try and combine efficiency in terms of assessment and also permit a more proactive approach to intervene in higher risk individuals before they become ALC, either developing delirium or acquiring functional decline in the hospital. Can we identify these people at risk for these outcomes before the outcomes occur, in order that we may target specific interventions aimed to preventing problems? So these are the hospital systems, and they are meant to support assessment of clients at multiple levels. The structure includes brief screeners, followed by more lengthy assessment systems, either for a more intermediate look at the person's characteristics, or for the really high risk individuals, more lengthy assessments. So in the emergency department, we'll talk about some of the instruments, the ED screener, as well as the ED contact assessments. For more complex individuals who've been identified with these briefer screeners, there are the acute care geriatric assessment and the mental health assessments. And finally, for those who need rehab, we have the equivalent assessment. The final assessment is intra-acute care, which is designed as a basic nursing intake instrument for any person admitted to hospital, whether they come in through the emergency room or as an elective patient. For the purposes of the CFN grant, we looked at the ED screener, the contact assessment, and the acute care comprehensive geriatric assessment. The project was in 10 hospitals in 3 provinces, and like I noted, they involved those 3 aspects of the hospital suite. The assessment urgency algorithm has been used in Ontario and other areas in Canada for many years. It's part of the home care version of the contact assessment, and it's being implemented in some emergency rooms in Ontario and elsewhere. And essentially, this is meant to be a 1-minute or so assessment that uses a decision tree logic. The main indicator to determine to start separating the groups into more refined groups in terms of risk is self-reliance. So if these people need assistance in IADLs or ADLs, that's the first decision point. And if you were to say follow the self-reliance indicator, assuming your client is impaired, then the next question is whether the family is overwhelmed or not. And if the family can't handle the stress or the burden, that places you immediately in a high-risk category. You can follow the algorithm through other decision points for other patients that you might know, but the ultimate endpoint is 6 levels of risk, as opposed to many other instruments which dichotomize risk as high or low. And in terms of health services planning, it's more useful to have multiple levels of risk, especially if resources are an issue and you want to be more efficient with targeting individuals at the highest risk. So the protocol was this. We looked at all comers 75 years and older presenting to the emergency room. They would undergo the ED screener, which is the assessment urgency algorithm I just showed you. Those who scored 5 or 6 on the ED screener went ahead and had a ED contact assessment, which is a 15 to 20-minute assessment that looks a little bit more in depth at some of the issues in the ED screener. Those who were admitted to hospital and remained at high risk underwent the full acute care comprehensive assessment. So here's some of the preliminary results. In terms of the ED screeners in the 10 hospitals, we ended up with a sample of close to 5,100 patients presenting to the emerge, over 75. Obviously, the hospitals varied in size, and therefore the sample size was dependent on the hospital size as well. About 40% or so of the patients who were assessed with the ED screener were women. This is the distribution of ED screener AUA scores of 5 or 6 across the 10 different sites. And again, it varies between a little over 20% in some cases to almost 50 to 60%. And again, we're going to be going through the data, but this likely reflects the setting of the hospital and the acuity of the population that they serve. In terms of the contact assessment, so remember, if the ED screener AUA score was 5 or 6, the patient then underwent the contact assessment, which is a slightly longer, still screener level instrument, about 15 to 20 minutes. So overall, almost 1,400 patients underwent a contact assessment. You can start seeing changes in the characteristics of the patients being assessed. More of them were women, and their age is in the low to mid 80s. One question, obviously, is how well does the ED screener AUA score match up with that of the contact assessment? So for 74% of those who had the contact assessment, there was complete agreement in about 74% of these cases. When there was disagreement, most of it was off by at most 1. So if the AUA, for example, had scored a person as having a risk of 5, the contact assessment might most of the time agree with that. In other cases, at worst, the deviation was of 1, so the person was still a relatively high risk based on the contact assessment as a risk of 4. So the agreement, again, for a 1-minute app compared to the 15 to 20-minute assessment was actually quite good. One of the useful outcomes from the ED contact assessment, and again, remember the setting, you are getting this in the emergency room before the patient has even been admitted, is a score called institutional risk. And we'll look at risk of ALC for these folks subsequently. But the institutional risk scale gives you a score of 1 to 5. Most inter items and scales work with low scores meaning lower risk and high scores meaning high risk. And from a human resource health system planning perspective, you can see that this allows you to identify various levels of institutional risk from the get-go, from the emergency room. And for example, if you look at people at the high risk of institutionalization, you're able to pick up perhaps 20% at most of the sample coming in through the emerge may be identified as high risk, which makes it very helpful in terms of planning how this person's hospital admission is going to go. Before they even hit the ward, you already know that this person has characteristics of an individual who's at risk of becoming ALC and then requiring long-term care placement. So from the perspective of how can we identify people early in order to institute senior-friendly interventions as quickly as possible, this is a potentially very helpful instrument. Moving on to those who were the highest risk based on the contact assessment, who underwent the comprehensive assessment, which is an instrument that takes about 75 minutes to 2 hours for most patients. About 800 were collected, and I'm going to present 356 assessments from 4 of the main hospitals for which we've compiled the data thus far. So as John showed, one of the nice things about these instruments, because they are standard, is you can compare across sites. So over here, we're looking at cognitive performance scale, and on the right, we're looking at ADLs. And the 4 hospitals are color-coded based on the orange, red, green, and blue. I think one of the important notes, if you look at cognitive performance scale, 0 being intact, at most, 35% of these folks presenting to the emergency were subsequently shown to have intact cognition, which means that 65% of them do not have intact cognition. This is critical because most of these people come in with chronic illnesses for which self-management interventions are a cornerstone of successful management. And if 65% of them have some cognitive impairment, that has major implications on how you're going to plan the discharge. Similarly, in terms of activities of daily living, 0 is intact and 6 is basically requiring total care. Very few of these people have intact function when they hit the emergency room. There's an awful lot of functional impairments in these hospitalized patients. And we know that if you hit the hospital with functional impairment to begin with, you are at increased risk of further functional impairment and therefore becoming ALC. Importantly, about 30% of these people with cognitive impairment had delirium based on the acute geriatric assessment, which uses a screening instrument based on the CAM, the confusion assessment method. Now, how do these acute care patients from this study compare to hospitalized, institutionalized, or patients across the system? And this was quite sobering. I mean, I'm a geriatrician. I've done work in a variety of sectors, including acute care, and it is quite sobering to see how these hospital patients compare to other settings. So here we focus on cognitive performance scale. Again, 0 is intact, 6 is comatose. You've got samples from psychiatry, palliative care, community mental health, community support services, home care, those who had the acute care geriatric assessment with the high risks, complex continuing care hospitals, geriatric psychiatry, and nursing home. And if we look at how the hospitalized patients compare, you get a sense that these people are actually very complicated. And I'll show you in the subsequent slide that they compare quite favorably to nursing home and home care clients in terms of their complexity and cognitive impairment. So if you look at home care, which is in green, acute care, which is purple, and complex continuing care, geriatric psychiatry, and nursing home, you can see that these acutely hospitalized patients have a very high prevalence of cognitive impairment, and their profile is very similar to that of patients in home care, and perhaps even people in complex continuing care. So these people are very sick, and we often don't realize how sick they are from a geriatric perspective. And again, the sicker they are, the more likely they are to become ALC. If we look at ALC, the length of stay for the entire group of these folks who had the AUAs of 5 and 6 was about 19 days. 71% had a length of stay over 7 days, 40% over 14 days, and 30% or 16% had a length of stay of over a month. One of the interesting predictors was ADLs on admission, and we saw how many people have functional impairment on admission. So functional impairment based on the ADL score greater than 3, over half of these people ended up having a length of stay of over 2 weeks. So again, knowing ahead of time who's got functional impairment, we can start thinking about who's going to require more physical activity interventions to prevent prolongation of length of stay in ALC. So in short, what we've shown is that we were able to successfully implement a major chunk of the hospital suite in 10 hospitals. We've shown that there's very good agreement between the brief ED screener and the subsequent contact assessment. And we've demonstrated, I hope quite convincingly, that this approach can identify the characteristics of patients who are being admitted who are at risk for institutionalization and risk for increased length of stay. And so implementing this suite makes possible an approach for efficient and logical targeting of senior-friendly measures to prevent ALC and premature institutionalization. Again, we know there's good evidence for physical therapy for senior elder life programs to prevent delirium and functional decline as long as we get to these patients before they deteriorate. And this speaks to a more efficient approach to targeting, and also an approach that allows institution of proactive best practices before the patient has had problems with iatrogenic complications. It streamlines the documentation across sectors and within the hospital. Not everyone needs the fulsome assessment, and so the assessments, the complex assessments, are only done on people who will need these to be done. In addition, we're looking at assessments that are already in place in the community as well as other areas. So you can envisage that this will allow you to integrate with home care and long-term care, both for incoming patients as well as those who are being sent home. And the ability to do standardized assessment across sectors allows for robust quality assurance across the system. Again, you cannot compare truthfully how hospitals and other institutions perform if they're not measuring things the same way. And that speaks to the whole notion of trying to provide equitable care for all Canadians. To finish off, we'd like to thank the participating hospitals, the Canadian Frailty Network, as well as the partners who worked with us on this work. And I think at this point we're done, and we'll just turn it back to our moderators.
Great, thank you very much. And so we have some time now for questions. I encourage attendees who do have questions for our presenters to please enter them into the chat box, and we'll get to as many as we can in the next 10 to 15 minutes. And so I'll start it off here with a question about the age group. So what age groups can the Acute hospital suite be applied to? And specifically, what about the younger adults who may be living with frailty but not quite in that oldest category?
The instruments have been used, again, 75 years and older was picked because these folks are more likely to have these issues related to frailty. But there's certainly no reason not to apply the instrumentation to younger groups. And so if you want to apply it to people who are 65 and over, or if you're in an area where potentially in areas that are challenged in terms of socioeconomic status, I think there's no reason why these instruments could not be used. Again, these instruments are used to assess functional problems and frailty, and again, frailty does not have an age limit. So, but for the purposes of the study, you use 75 and over, but there's no reason that you cannot use it for younger individuals.
Well, there's actually two different acute care instruments for the inpatient side. There's the ACCGA instrument that we showed here that is going to tend to be identified when you've got an older person with complex needs and with living with frailty. But there's also a shorter instrument called the intra-acute care that our Australian colleagues are using with all adult admissions for adults age 18 and over. And what's been interesting in their research is that they found even in that population, they pick up a lot of indications of complexity that weren't really systematically detected before. And I think one of the things that it reflects is that inpatient stays in acute hospitals today are rare enough that they tend only to be the people with the most complex needs, including younger people with complex needs. So that shorter acute care instrument could be used with all age groups.
Okay, great. And we have a question here just about the last part of your presentation here, George. You presented length of stay, some findings, and was that ALC length of stay or was that total hospital length of stay?
It was total hospital length of stay.
Okay, great. And another question coming in, if you could clarify the difference between the ED screeners and versus the frailty screeners, just for some clarification here.
So the ED screeners, there's two levels. One is the ED screener per se, which is the essentially the assessment urgency algorithm, and that takes a minute, and that's the decision tree that we showed. The ED contact assessment is similar to the home care contact assessment, and that's a slightly lengthier instrument, about 15 to 20 minutes, which delves a little bit more deeply into some of the issues, again, related to cognition, function, caregiver support. And so the way that this was meant to be used is, can we do a very quick triage using a very brief instrument in order to identify the groups for which we need to take a little bit of a closer look. Things like the TRIST, things like the ESAR, they're all meant to take very little time, and that's because the emergency room is basically a pressure cooker in terms of time. If the AUA identifies risk, then the ED contact assessment, which is a little bit longer, is designed to start looking at some of these matters a little bit more closely to verify, essentially the screener's assessment, and to start identifying issues that could potentially be worked on, whether the person is sent home. They might be identified as requiring a home care referral, or whether they're hospitalized, they might be identified as requiring the full assessment or specific interventions such as social work or early physiotherapy.
I'll just add a couple things for the folks who are listening. If you have an Android device or an Apple device, just go to either Google Play or the Apple Store, search for Intra. You'll find the ED Screener app there. You can download it for free and you can use it at any time. It's an app that does not collect data. The ED Screener app is designed to use decision tree logic, so it asks the fewest questions possible to quickly categorize you in the AUA decision tree algorithm. So you could classify somebody with as few as 2 questions or at most 8 or 9 questions. The ED contact assessment is the same contact assessment that home care agencies in Ontario use for intake into home care from hospital or community, and several other provinces are looking at using the contact assessment as well. So this is just the emergency department version of that. So it means that the ED Screener, ED contact assessment tool that you use is consistent with the intake tool that home care agencies use in several provinces.
Great, thanks. We have a question here about the seniors' mental health condition. So is there separate data for this? So similar to how many ADLs at entry or to the emergency department, like affected hospital stay? Any specific data on that population?
Yeah, so virtually all of our intra instruments include depression measures. In the newer instruments, we include both self-rated mood items around depression, anxiety, and anhedonia. And we also have clinician-rated items around depressed mood. In addition, we have the cognition measures, the delirium measures, behavior indicators, as well as items on hallucinations, delusions, and abnormal thought processes. So we actually have huge capacity to look at older adults with complex mental health needs across different service settings, including inpatient psychiatry, where we have over 1.3 million intra mental health assessments on adults of all ages in that setting.
Okay. And another one here. How can health service providers use your tools to look at who's at most risk for those who are receiving services right now, who are already in the system?
So there's 2 ways. One is that any healthcare organization that wishes to adopt an instrument can do so. We provide access to our instruments at no cost. We entered data sharing agreements with organizations so we can do the kind of research that we've done today. So you can use these systems yourself, and we're happy to talk to you about which instruments might be a best fit. But the other thing is you should ask for these assessment results from partner organizations in the circle of care. So one of the things that should be readily apparent now is if you're in an acute hospital and you have somebody that's been admitted to your emerge from home care or long-term care, it makes sense to ask for their most recent assessment. So another research project that we're doing, we were able to show that the previous home care assessment has data elements that will predict a transition to ALC status for patients admitted to hospital. So a critical thing for healthcare to function as a system is that partners in care share the data, use the data clinically, work together collaboratively based on that common source of evidence. And that's probably one of the biggest challenges we're facing right now in Canada, that we have widespread adoption of these systems, but there tends to be a siloed approach to using the assessment. There's not enough sharing happening, and that's one of the things we want to see change.
And I'd point to a paper co-authored by Alan Detsky, published in JAM a couple of years ago, that talked about what we should be looking for as a smart electronic medical record. I think of my work when I work in a hospital and I log on to look at a person's lab results. I will have someone's hemoglobin flagged at me in some sort of color, so I know I can log on and I can see what issues are going on. And in a smart EMR, that's what you should be looking for this kind of information. You should log on and notice that the person's potassium is high, but you should also have a flag telling you that the person's delirious or at risk of delirium, that the person's experiencing functional decline, that the person needs some physiotherapy. And so there's 2 things. There's the information sharing, and I will go out of my way to phone home care and get the intra assessment over, including its summary. And when I do that, I can cut down my assessment time by about 50%, which makes me more efficient and doesn't waste the patient's time for me asking the same questions over and over again. So I find it personally useful, but one of the issues is the purchasers of electronic medical records do not think in those terms. And I think that is a very significant issue, across the country about how we purchase and implement electronic medical records that give us information like this, that provide it to us without cluttering up our minds further, and actually do support our ability to identify issues quickly and provide the proper care.
Great. And so, George, you did mention earlier a senior-friendly care or approach. And we have a question about whether or not this is really about being senior-friendly, or if it's more about identifying interventions related to social support, social isolation, those of low economic status.
I think it's all senior-friendly, but senior-friendly or vulnerable-friendly. When we speak about ALC for older patients, people in the 75 age and above, we know that there's very good evidence for something like the Seniors Elder Life Program to prevent delirium and prevent functional decline. We have a lot of evidence that's emerging about preemptive exercise for frail persons, both who are expected to undergo surgery or who've just come in and are frail and have mobility impairment. So in that sense, we're targeting vulnerabilities. But similarly, if you identify people who are lonely, who have limited social support in the community, when do we actually think of that in the course of a typical hospitalization? So we think about it when we've decided that their pneumonia is better and they're ready to go. And then you have the oops moment where you realize that this person can't go home. And so whether you call it senior friendly or more broadly, perhaps more correctly, friendly to anyone who's vulnerable, having that identified up front allows the right resources, your social worker, your discharge planner, your home care coordinator, to start working and thinking about that patient while you're treating their pneumonia. So by the time the pneumonia is better and they don't need oxygen anymore, not only have they gotten the physiotherapy to remain mobile, but you've also got some plans in place to facilitate that discharge.
Great. And are there specific inter-eye tools that standardize those measures of the social determinants of health?
Yeah, I mean, all the intra-eye instruments that are the full assessments deal with different aspects of social determinants of health. So there's a lot of depth in terms of the nature of social relationships that people have. There's an excellent poverty measure that differentiates access to finances, or looks at economic trade-offs. We can look at sort of regional variations as well as cultural factors. Our main cultural measures are around preferred language, need for an interpreter, and indigenous status. Each of those are associated with important variations in outcomes as well. So all these intra-eye instruments are designed to be pretty broad-based in their approach to assessment, which sometimes leads to objections that there's too much there. But in fact, when we look at these complex populations, it's a variety of things that are going on. It's social determinants of health affecting them. There are mental health dimensions, environmental dimensions, somatic medical dimensions, functional status becomes important. You need that comprehensiveness to deal with the complexity of populations like older adults living with frailty, people with mental health concerns, or people who are dying. They're all complicated.
Great. So now I see that we've reached the 1 o'clock time point, so we'll have to bring it to a close. I just want to remind everyone that the app, you said you can search Inter-Eye on the App Store or Google Play to download. That's where it's the AUA. And otherwise, we thank you all for attending, and we'll hopefully see you at our next webinar on May 8th at noon. Thank you again, George and John.
You're welcome. Thank you.